Cholesterol has become one of the most controversial topics in medicine. Some say cholesterol doesn't matter. Others say statins, the medications used to treat cholesterol, are overprescribed and harmful. But here's the truth. The controversy isn't that statins don't work, and it's not that LDL doesn't matter. The real debate is who should be treated and how we interpret the numbers and how aggressive treatment should be. In this video, I'll show you how to understand your cholesterol values on blood work so that you can make informed decisions. We'll start by understanding what the values mean, and in the next video, we'll talk about whether or not medications would actually benefit you. We're gonna try a new style this time. I've received great feedback from the CBC teaching video that sometimes it was a little bit hard to follow. So in this video, we'll include more visuals, and if you like this style, please let me know so we can continue using it for future videos. First, cholesterol itself is not the problem. In fact, cholesterol is essential for life. We need cholesterol for cell membranes, hormone production, bile acid formation, and brain and nerve function. The issue isn't cholesterol itself. The issue is how cholesterol is transported and handled in the body. Cholesterol travels in the bloodstream inside these particles called lipoproteins, which differ in size, composition, and function. ApoB containing lipoproteins deliver cholesterol from the liver to tissues, while HDL particles help transport cholesterol from the bloodstream back into the liver. The ApoB lipoprotein most people are familiar with is the low density lipoprotein, or the LDL. LDL-C refers to the amount of cholesterol carried inside LDL particles. The risk increases when the particle number of the LDL is high. When too many particles circulate, they can enter the arterial wall, become modified, trigger inflammation, and then lead to plaque formation. Over time, plaque narrows and hardens the arteries. And if a plaque ruptures and a clot forms, it can suddenly block blood flow, causing a heart attack or stroke. That's why LDL is considered an atherogenic lipoprotein, meaning it promotes plaque formation. Importantly, all ApoB containing lipoproteins are atherogenic, not just LDL. When we measure LDL-C, as mentioned earlier, we're measuring the amount of cholesterol inside LDL particles, not the number of particles. We often assume LDL-C reflects particle number, but that's not always true. Also, LDL is not the only atherogenic particle. All ApoB containing lipoproteins contribute to risk. To measure particle number directly, we can test ApoB, which counts all atherogenic particles. Unfortunately, in Ontario, ApoB is not routinely covered and usually requires out-of-pocket payment, so it might not be practical for everyone. Later in this series, I'll discuss when ApoB testing is especially helpful for treatment decisions. So then, what's the alternative? This is where non-HDL cholesterol comes in. Non-HDL includes all the cholesterol covered by all ApoB containing lipoproteins. It's calculated simply as total cholesterol minus HDL cholesterol. It's not as precise as ApoB because it still measures cholesterol rather than particle number, but it performs much better than LDL-C alone. It does not require fasting, and it provides a more complete picture of risk. If ApoB isn't available, non-HDL cholesterol is often the most useful number to focus on. If high non-HDL cholesterol is problematic, does that mean the opposite? High HDL cholesterol is good. HDL earned that label of good cholesterol because it plays a role in reverse cholesterol transport, helping remove excess cholesterol from the bloodstream. HDL particles are not atherogenic and do not contribute to plaque formation. However, raising HDL levels with medications has not reduced cardiovascular events, and very high HDL levels have sometimes been associated with increased risk. This suggests that HDL function matters more than HDL level, but we can't measure HDL function. Because of this, we now view HDL-C as a risk marker, not a protective shield. This is why we don't rely heavily on the total cholesterol to HDL cholesterol ratio anymore, because a high HDL does not cancel out a high LDL or a high atherogenic particle burden. Instead, HDL helps provide context. Low HDL is associated with higher cardiovascular risk. This often reflects underlying metabolic issues such as insulin resistance, obesity, inflammation, or poor fitness. When HDL rises with lifestyle changes such as exercise, weight loss, or improved diet, it can be a useful sign of improved metabolic health. But the goal is not to raise HDL directly, especially if atherogenic particles remain elevated. Triglycerides are another type of fat found in the bloodstream. Unlike cholesterol, triglycerides are primarily used for energy storage. When you consume extra calories, especially from refined carbohydrates, sugars, and alcohol, the liver converts them into triglycerides. Although triglycerides themselves are not the primary drivers of plaque formation, elevated levels promote increased production of ApoB-containing particles, and they're also associated with insulin resistance and metabolic syndrome and contribute to inflammation and vascular risk. Lowering triglycerides can improve cardiovascular risk, especially when they are significantly elevated.
So how do statins work? Statins reduce ApoB-containing particles by blocking cholesterol production in the liver. In response, the liver increases LDL receptor activity, removing more ApoB-containing particles from the bloodstream.
Statins also produce modest reductions in triglycerides. This reduction in atherogenic particle burden is why statins lower the risk of heart attacks and strokes. Again, the controversy isn't whether or not statins work. The question is who actually benefits enough to justify treatment.
If your baseline risk of cardiovascular disease is already very low, the absolute benefit of a statin may be small. Like all medications, statins can have side effects, including muscle aches, which is the most common, rare but severe muscle injury called rhabdomyolysis, small increases in blood sugar, and mild liver enzyme elevations. For most people at moderate or high risk, however, statins are safe and well tolerated.
Now that you understand what cholesterol numbers actually mean, the next step is putting them into context. Because when it comes to treatment, what helps one person may offer little benefit to another. In the next video, we'll go through the Canadian guidelines to answer the key question: who is likely to benefit from statin therapy and who may not? The goal of this channel isn't a fear or one-size-fits-all advice, but a holistic, evidence-based approach that helps you make informed, individualized decisions. If you find this content helpful, please share this video and subscribe for more.